Good afternoon from Kuala Lumpur, Malaysia. Thank you very much for inviting me to be part of the second James Hakim Memorial Lectures and I'll be speaking on the impact of COVID-19 on the HIV Cascade. Since the beginning of the HIV pandemic, we know that close to 80 million people have been infected with the virus and more than 36 million people have since died. But in the last decade or so, we have seen significant decline in both new HIV infections as well as deaths from HIV, thanks to the advances in antiretroviral therapy and other related programs. Nonetheless, we're still very far from our targets to reach to end AIDS by 2030. And as you can see in this graph, we are more than 4 million behind in the first 95 target. We're close to 7 million people behind in terms of being on antiretroviral therapy, and more than 7 million people still have not reached the desired undetectable levels. And this was before the COVID-19 pandemic came upon us in December of 2019, with now more than 500 million people infected with COVID-19 and more than 6 million deaths in just over 2 years. That has disrupted health systems and around the world and caused major economic disruptions in nearly every country around the world. When COVID-19 reared its head, it became very obvious that this was going to lead to these major disruptions, and modelers began work on estimating the impact that this would have on HIV, TB, and malaria programs. As you can see, they modeled scenarios that included no action taken by countries to stringent action taken by countries, and compared country setting 1, which is a country with high disease burden, compared to countries with lower HIV burden. And what they found was that in high burden settings, it's estimated that over the next 5 years, there would be an increase by up to 10% HIV-related deaths compared to if there was no COVID-19 pandemic, and that the greatest impact will come from interruption to antiretroviral therapy, which could occur during a period of high health system demand. And the disruptions that could occur at every step of the HIV treatment cascade, from a reduction in testing availability, either due to lockdowns or decrease in the number of HIV clinic services as human resource gets deployed to look after COVID-19 patients. Disruption in supply chain could also result in a reduction in the availability of antiretroviral therapy. So that's from the point of view of the challenges that COVID-19 pose to the HIV care continuum. But obviously, the level of disruption would depend on the severity of the non-pharmaceutical intervention measures taken by each country, the burden of disease, of COVID-19 disease, and the resultant level of health system disruption from those two factors, and whether the HIV services in a rural or urban setting and how that would impact services and individual as well as country level socioeconomic status and the ability to respond to COVID-19 either as an individual or as a country. And we saw throughout these last 2 years how each country responded very, very differently as to the level of severity of the measures taken. Certainly in April of last year, at the height of the Delta surge, many countries took stringent measures to overcome the onslaught of the Delta wave, with the darker red indicating more stringent index. But as the vaccination programs, or at least in where countries where vaccination rollouts have been able to take place, and a reduction in number of new cases, or at least in the severity of COVID-19 disease, and reduction in mortality as a result of effective vaccination, many countries, as we know, around the world have loosened up their COVID-19 pandemic measures, with the exception of here, still in some countries in China and in the Far East. So without a doubt, this would also result in different levels of disruption to HIV services. In the next few slides, I will share with you some of recent articles and results from evaluation of large HIV programs around the world. This first one, which was recently published in CID, looked at the impact of COVID-19 on HIV services in 11 sub-Saharan countries, involving more than 1,000 health facilities. And they compared the changes in HIV testing between October and December 2019, in the first quarter, to the last quarter, which was July to September of 2020. And they also compared between countries that undertook stringent COVID-19 measures compared to countries which had less strict COVID-19 public health measures. And the red line denotes countries that took more severe measures, and the broken lines from countries that had somewhat looser COVID-19 pandemic measures. And what they found was, overall, not surprisingly, in countries with stricter measures, saw a reduction in HIV testing when comparing first quarter, which is in 2019, compared to number of tests done in 2020. However, in countries with less strict measures, paradoxically, overall, there was an increase in HIV testing. And when you look at it from different types of health facilities, not surprisingly, in fixed health facilities such as VCT services, as well as outpatients department and inpatients in countries that undertook stringent measures, not surprisingly, there was marked reduction in testing activities, whereas in countries with less stringent COVID-19 measures, data showed that there was, in fact, an increase in the number of testing activities in different, not only in different health facility types of facilities, but also overall increase in HIV testing. So there was also an increase in the latter part as we became more familiar with the modes of transmission, and as well as the different types of measures. As you can see here, there was an overall increase in number of HIV tested and new ART initiations in 2020 compared to 2019, at least in this more than 1,000 health facilities in Sub-Saharan, in 11 Sub-Saharan countries. The authors suggested that the rebound in HIV services seen in 2020 was as a result of expansion of existing DSD models in these facilities, coupled with innovations such as multi-month dispensing, community-led ART distribution, as well as pivot towards digital and virtual consultations and services. The authors did say that the limitations of the studies that these were done in selected health facilities and may not be representative of all health facilities in 11 countries involved. And the data thus far is only for 1 year and may not capture the full effects of COVID-19. So it'll be interesting to see as more data come in, how in fact the disruption will play out on COVID-19 services. Now, the second evaluation was a retrospective cohort study by AIDS Healthcare Foundation from 4 continents involving 44 countries, and they too compared HIV testing and number of new enrollments in HIV care and the overall percentage of positive results from 1st January 2020 to 31st August 2020, comparing it with an equivalent period in the year before. And once again, there was a large reduction in the number of and percentage of HIV testing throughout throughout the program in all 4 continents. And they also compared with different key populations and how significant these were with different members, with different key population groups. The services were most impacted was for sex workers, followed by transgender people, MSM, and to a lesser extent, quite surprisingly, I must say, with people who inject drugs. The authors describe some of the actions taken to overcome the challenges faced by the different key populations in these different countries, and they included some of those that I mentioned before, including multi-month dispensing, digital, pivot to digital services, and community-led services. Over and over, you'll hear that these were the key innovation taken that perhaps have kind of cushions what would have been a worse impact of COVID-19 on HIV services globally. And finally, in terms of large programs, an evaluation by the Global Fund also showed a reduction in percentage of people being tested and people reached with HIV prevention services. But overall, with Global Fund Global Fund programs, again, there's been an increase in the number of people on antiretroviral therapy, despite the challenges brought about by COVID-19. So all in all, although there have been major disruptions, particularly with testing in HIV programs, as reported by some of these very large HIV programs in different countries around the world, we do not have data on mortality as yet for HIV, but the Global TB program has in fact reported an increase in the number of TB deaths, both among HIV negative people and among people living with HIV, setting back the Global TB program, which in many ways was just beginning to have great success, leading or going towards the ending TB aims. But COVID-19 has set them back, or set us back to a level of 2017. Now that's from population level, but without a doubt, as we've heard throughout the COVID-19 pandemic, that it has impacted different individuals differently, and certainly in the last few minutes, I will share with you, the extent that COVID-19 has impacted members of key population and individuals around the world. And certainly there was a reminder to us all in this publication in GIAS of the need to really pay attention to members of key population who may, more than others, have significant challenges as a result of COVID-19 restrictions, as a result of perhaps more police scrutiny on members of key population during lockdowns, and other disruptions brought about by COVID-19. Here in a cohort study in North America of people living with HIV who also use drugs, some of the factors that can increase the likelihood of these participants or members of this cohort missing a visit include if they had unstable housing, food insecurity, low resiliency, and disruption to mental health and substance abuse services. And likewise, the likelihood of them missing a dose of ART was also higher in the men and those who've seen disruption in mental health and substance use services. Next few slides, I want to share with you the qualitative study from Thailand, kind of highlighting and bringing forth the deep psychological impact that COVID-19 has had in this small group of participants in this qualitative study of men who have sex with men in Thailand, around the worries and anxiety that they had about COVID-19 and about fear of HIV status disclosure and stigma. Secondly, on the impact of COVID-19 on the economy and their own employment. And finally, on HIV service delivery and how some of those changes may lead to the HIV status disclosure. And I quote from one participant, "I felt extremely scared and paranoid. I didn't dare to go anywhere. If I contracted COVID-19, the local authorities would make public announcement and my details would appear in headlines and people will know my HIV status," said a 30-year-old MSM. Another said, "I haven't worked for 5 months and skipped meals to pay for my rent and utilities. The stress from COVID-19 has impacted me personally on a daily level, so I avoid eating during daytime. Every day I get up and check on which hotels and restaurants are open and knock on each hotel door asking for a job in the area. I haven't been successful yet." And lastly, on the impact that it has had in terms of the fear about the underlying HIV status itself. "I felt scared of the idea of receiving HIV medication via post. I remember an incident in the news when the postman opened someone's package and I thought if they opened my package and found out my HIV status, they would be disgusted with me and my family." So without a doubt, the last 2 years has brought about significant disruption in access to services, reduction in resources that have led to decrease in HIV testing, in access to antiretroviral therapy. But as you also saw, at least with some of these big programs, innovations and resilience and perhaps the strength of existing HIV services that had already innovated in terms of differentiated service delivery and task shifting, community-led services have perhaps cushioned us, or at least the HIV programs, and not suffer as badly as was initially predicted. So in closing, I think these were the 5 strategies that the IAS and colleagues from FHI have recommended to see us through, particularly for key population-focused HIV programs in the era of COVID-19 that have already been adopted, as you can see, by many programs around the world, including decentralization of services, wide-scale use of digitization, multi-month dispensing, and especially the great involvement of community and community-led services. So with that, I'd like to end by thanking the organizers for inviting me to this presentation this afternoon. Thank you very much.